This conference will now be recorded.
So good afternoon all. Am I audible to you? Am I audible? Someone respond?
Yes, ma'am.
Okay, thank you.
Yes, ma'am.
Okay, thank you. So today's topic is management of gestational diabetes. Nowadays, there is increased incidence of gestational diabetes in a pregnant woman due to many factors. One of them is obesity, Western type of food habits, etc. So it is very important to know to how to diagnose a gestational diabetes and how to manage and how to evaluate and how to treat. So diabetes in pregnancy, obviously there will be more food cravings in pregnancy, which in turn leads to glucose intolerance and diabetes in pregnancy. The scope of diabetes and pregnancy encompasses gestational diabetes and pre-gestational diabetes. Gestational diabetes is something we found after 24 weeks of pregnancy. Then we'll call it as the gestational diabetes. It is firstly diagnosed in pregnancy only. If it is pre-gestational, if we diagnose a case of diabetes before 24 weeks or in first trimester, then we'll call it as over diabetes or chronic diabetes. So it is type 1 and type 2. Coming to definition, carbohydrate intolerance of varying degrees of severity with onset or first recognition during pregnancy. This is very important. It is gestational diabetes means it is firstly recognized in only pregnancy, but whether or not insulin dependent, whether or not diabetes persists after pregnancy. Generally, gestational diabetes do not persist after delivery. It usually resolves in 2 to 3 weeks. Coming to classification, it is there are two types of managements. One is diet and exercise. We can control glucose intolerance by simple changes in diet and exercise. Secondly, if we tried diet and exercise for 2 weeks after diagnosis of GDM, there is no control, then we'll go for pharmacological therapy. First, you have to use oral hypoglycemic agent, then we'll go for insulin. Coming to prevalence, globally it is a 3 to 10% in previous years. Now it is increasing up to 18%. This is mainly due to sedentary lifestyle, dietary habits, obesity, or older age at pregnancy. Previously, women used to complete her family by age of 21 years. Now, marital age for a woman is 21 years. So it is prolonging till 30 to 35 years to complete family due to other commitments like work and all. So this is also an important factor nowadays in the life of a woman. Other causes of PCOD and increased awareness and testing. Previously, there is no rule for universal testing, and we do not recognize GDM until it leads to fetal complications and maternal complications. So increased awareness and testing also leads to increased prevalence. So magnitude of problem, prevalence of GDM in India is 16.5. It is very high relatively. India is diabetes capital of the world. Hyderabad is the national capital of world. So all the diabetes is concentrated in and around us. Indian women were 11 times more prone for GDM. In the next 2 to 3 decades, diabetic women population in the reproductive age group will be 8 crores worldwide and 2 crores in India. almost 1/4 in India. So coming to risk factors might be in past history, personal history, and laboratory factors. In past history, GDM in previous pregnancy, perinatal loss, pre-pregnancy weight more than 110% of ideal weight, associated medical conditions like metabolic syndrome, PCOS, hypertension, cardiovascular disease, uses of corticosteroids, personal history, age more than 25 to 30 years, ethnic group, BMI more than 30 kg per meter square, and multiple gestation. Laboratory findings like if HbA1c more than 5.7, less than 5.7 it is normal range, and glycosuria in first visit, and HDL less than 35, and triglycerides more than 250. These are all the risk factors for developing gestational diabetes mellitus. Why it is important to diagnose and treat? Two generations are at risk of developing diabetes in the future. So if woman is having diabetes, gestational diabetes in this pregnancy, there is a risk of next two generations getting affected. Coming to pathophysiology, pregnancy is a diabetogenic state. Increased instance resistance due to placental secretion of diabetogenic hormones like growth hormones, cortisol releasing hormone, placental lacto, and prolactin and progesterone. Early gestation insulin requirement is less as fetus acts as a glucose sink, decrease substrate available due to nausea and vomiting, and insulin sensitivity, enhanced maternal insulin secretion. Coming to second and third trimester, increased insulin resistance, antagonist effect of HPL, estrogen, and progesterone, accelerated insulin catabolism by placental insulinases, increased lipolysis and alteration in glucogenesis, impact of maternal hyperglycemia and maternal morbidity. So what are the impacts of hyperglycemia on mother? It can lead to PAH, pregnancy-induced hypertension, polyhydramnios, preterm labor, infection, hypoglycemia, and dreadful complication of diabetes like diabetic ketoacidosis, worsening of chronic problems like these are sequelae of diabetes like neuropathy, retinopathy, nephropathy, and cardiomyopathy. These are relatively rare but serious complications. Coming to fetal morbidity, macrosomia, congenital malformations, miscarriage, preterm delivery, IUGR, mostly in case of type 1 diabetes mellitus due to vascular disease. In case of GDM, that is gestational diabetes mellitus, we will get macrosomic babies, whereas in case of type 1 diabetes mellitus, due to vascular disease in the woman already pre-existing, we will get IUGR babies. Respiratory distress syndrome, hypoglycemia, hypocalcemia, hypomagnesemia, polycythemia, and hyperbilirubinemia. Fetal and neonatal effects, growth abnormalities, fetal oxygenation problem, chemical imbalances, and long-term sequelae like obesity, glucose intolerance, and diabetes mellitus. Coming to risk categorization, low risk, average risk, and high risk. This group comes under low risk based on ethnic group. No known diabetes in first degree relatives is less than 25 years. Normal weight before pregnancy, normal weight at birth. No history of abnormal glucose metabolism. No history of pure obstetrical outcome. Age more than 25, ethnic group with high prevalence of diabetes. Diabetes in first degree relative. Weight high as at birth. All come under average risk. Whereas severe obesity, strong family history, previous history of GDM, these will come from high risk. So coming to screening strategy, whom to screen, when to screen, and how to screen. These are the three questions we have to know before screening. Whom to screen? When to screen is first antenatal visit. Whom to screen? High risk women only with the high risk like obesity, family history, and past history. How to screen? Screening blood sugar and random blood sugar. If HbA1c is more than 6.5 and FBS is more than 126, RBS more than 200, then we'll term it as over DM. If it is 5.7 to 6.4, then it is gestational diabetes mellitus. If it is less than 5.7, it is normal. We have to repeat the screening test, glucose tolerance test at 24 to 28 weeks. Coming to routine screening, at 24 to 28 weeks, two-step approach. Step 1, oral glucose challenge test. First, we have to go for without regard for time of day, first or last meal. 50 grams of oral glucose given. After 1 hour, blood glucose is checked. If it is more than 140, or more than 130, we have to see. Then we'll, if it is more than 140, then we should go for glucose tolerance test. In this, we'll give 100 grams of oral glucose. Then we'll check FBS first hour and second hour and third hour glucose with overnight fasting. Among these values, if two values are deranged, then we'll categorize it as a GDM. One step approach, we are following this nowadays. It is simple. After overnight fasting, without regard for time of day or last meal, 75 grams of oral glucose is given, and fasting 1 hour and 2 hour samples are collected. These are standard values. If fasting is more than 92, or 1 hour sample more than 180, or 2 hour sample more than 150, if one value is raised also, we will categorize that as glucose intolerance and gestational diabetes mellitus. Coming to DIPSI guidelines, Diabetes in Pregnancy Study Group of India. One-step method irrespective of fasting for better compliance in low resource setting. We'll give 75 grams of glucose. After 2 hours sample is taken. It is more than 140 GDM, more than 200 is diabetes mellitus, over diabetes mellitus. So management of GDM, we always strive for maternal euglycemia. There should not be hypoglycemia or hyperglycemia. We should maintain euglycemia in the mother. It is always a team approach. Obstetrician, diabetologist, dietitian, and pediatrician should be involved in this management. Coming to structured approach, first one is patient education, antenatal care, that is metabolic control and fetal evaluation. Delivery, it might be normal labor or LSCS. Postpartum care and follow-up. Coming to preconceptional counseling, need for tight glycemic control prior to conception. That is HbA1c should be less than 6.1. Regular diet, exercise and weight loss. Risk of malformations associated with unplanned pregnancy and poor metabolic control. Review of drugs, AC inhibitors and angiotensin receptor blockers and statins. These should not be used. Prenatal vitamins like at least 400 mg of folic acid. If there is a diagnosed case of folic acid deficiency, we have to give 5 grams of folic acid. Smoking cessation, family planning and effective contraception. Coming to preconceptional testing, diabetic specific testings like HbA1c, TSH and renal assessment and retinal assessment before planning pregnancy. And termination of pregnancy, after doing this preconceptional counseling, when to suggest a mother to get aborted or MTP, medical termination of pregnancy. If HbA1c is more than 10, risk of congenital malformation is very, very high, that is 22%. So patient may opt for MTP. It is not compulsory. It is always a option in the hands of the mother. Severe diabetic retinopathy. In this case, there will be high mortality rate. So a patient might can opt for MTP. Coming to patient education, implication of GDM for her and baby, diet and exercise recommendations. self-monitoring of blood sugars, self-administration of insulin, identification and treatment of hypoglycemia. We should educate the woman about all these things. Coming to diet, pregnancy is not the time to plan for weight reduction. Adequate nutrition to the mother and fetus, avoid excess weight gain and hyperglycemia. Calorie intake, if a woman is underweight, she can take 35 kilocalories per kg per day. If normal 30, overweight 25, and obese 12 to only 12 to 14 kilocalories per kg per day. Calorie distribution, protein should account for 20% of the diet, fat 30 to 40, and carbohydrates 40%. And breakfast should account 10% of the calorie intake, lunch 30, dinner 30, and snacks 30%. Diet recommendations: 3 meals plus 3 snacks. Breakfast 2 parts, 2 hours apart, high fiber diet. Bedtime snacks: complex carbohydrates which have low glycemic index. Protein at every snacks and meal. Low fat diet, fat food. Raw salads of vegetables and high fiber rich grains and cereals. And skimmed low fat milk. You should know what are the foods with low glycemic index and high glycemic index. You should always advise the patient to take low glycemic index of foods like corn, beans, oats bran, peas, whole wheat bread and whole grains. These are foods with a high glycemic index like melons, pineapples, cornflakes, popcorn, white bread, and rice. So these patients should avoid all these foods. Some dietary tips: sugar and concentrated sweet should be avoided. Convenience foods and fried foods, tea, coffee, whole milk, high glycemic index food should be avoided in pregnancy. So what is the role of dietitian? Calorie redistribution, calorie requirement, carbohydrates less than protein, complex carbohydrates. They should advise to take complex carbohydrates. Exercise. Recommended forms of exercise are moderate exercises, not severe exercise. Walking, stationary cycling, yoga, low impact aerobics, and 10 minutes of low arm exercise. Exercise should be done 1 to 3 hours after food. Facilitate glucose utilization increased with insulin sensitivity. ECOG recommends 30 minutes or more of moderate exercise. Avoid starting of new below trunk muscle exercises. Exercise heart rate should not exceed 140. Exercise is safe at a blood glucose of 90 to 140 mg. To palpate uterus during exercise to detect contractions. Oral hypoglycemic drugs. These are only 2 drugs we use in pregnancy. Rest all are not safe in pregnancy. One is metformin and glyburide. These are only 2 drugs. Mechanism of action is metformin will increase sensitivity to insulin, increased insulin-induced glucose uptake. It is dose is 500 mg OD or BD or 1 gram BD. It crosses presenter, so it is a category B drug. It is its failure rate is 35%. Similarly, glyburide stimulates pancreatic beta cell insulin release. Dose is 2.5 mg OD or BD, max up to 10 mg. It also causes placenta. It is category C drug. It is 20% failure rate. No studies on long-term safety on oral hypoglycemic agents. Not FDA approved. According to ACOG, oral hypoglycemic agents are not recommended in pregnancy. So we always go for insulin in case of hypoglycemia in pregnancy. Goal is to maintain fasting blood sugars less than 95, and postprandial after 1 hour it should be less than 140, and after 2 hours it is It should be less than 120. These are the required targets to be reached with insulin. If blood glucose not controlled with diet and exercise in 1 to 2 weeks, and if fasting sugar is more than 126 mg per deciliter, we directly start insulin. Human insulin is least immunogenic. Generally, we go for human insulin. Types of insulin: rapid acting, short acting, and intermediate acting, and long acting. We all know this. Coming to insulin monitoring, intensive and conventional. Intensive monitoring will check 7 times a day. That is pre-prandial 3 times, post-prandial 3 times, and midnight test at 2 a.m. 1 time. Whereas conventional test we can check 4 times a day, fasting 1 time, and postprandial 3 times. When to monitor? Monitor every 3 to 4 days after achieving target values. We can check once a week. Why to monitor? Fasting and postprandial to achieve metabolic control. Postprandial is directly high postprandial blood sugars is directly proportional to macrosomia, neonatal hypoglycemia, and PAH. Recommended target goals. Fasting should be less than 95, 1 hour postprandial less than 140, 2 hours less than 120, 2 to 6 a.m. test at midnight, it should be more than 60. HbA1c should be less than 6. How to administer? It is safe to administer with pen injectors. It is best, and it is individualized. How much to administer? Route of administration is subcutaneous. Site is abdominal. Abdomen is more safe than arms and then thighs and buttocks. Dose calculation of insulin. First trimester 0.7 per kg. Second trimester 0.8 units per kg, and third trimester it is 0.9 and 1 per kg. Multiple daily insulin injections. Start with 3 to 4 units of regular insulin 30 minutes before food. Monitor fasting sugars and postprandial. If fasting glucose is elevated, we have to give long-acting insulin at bedtime. Insulin can be increased up to 8 units a day after every 2 hours, every 2 days. High levels of insulin attained at short intervals. This is protocol 2. This is mixed and split doses of insulin. Here dose 2/3 morning and 1/3 evening. Regular insulin 1/3 morning and half evening. 1/3 among 2/3 morning dose, we'll give 1/3 morning and 2/3 evening. Among this 1/3 dose, we'll give half morning and half evening. Fasting sugars and postprandial sugars should be monitored. Protocol 3, these are different protocols to give insulin. Basal and bolus protocol. Basal insulin glargine to allow uptake of glucose into the cell, whereas regular with meals to inhibit gluconeogenesis and lipolysis. This combination gives excellent glycemic control, max patient flexibility and satisfaction, minimum hypoglycemic episodes. So this is the protocol we generally follow. There are two phenomena, one is dawn phenomenon and Somyaji phenomenon, which is dawn phenomenon is common. Early morning physiological surge in growth hormone and cortisol and insulinopenia. Blood glucose stable all the night. The sharp increase in early in the morning, more aggressive insulin in the night will cause this phenomena. Don't eat a carb snack at the bedtime. And Somyaji phenomenon is least common. Excessive night time basal insulin dose. Hypoglycemia in the middle night triggers release of counter regulatory hormones. Hypoglycemia is 2 to 3 a.m. Decrease nighttime long acting insulin. Management of complications. First complication is hypoglycemia and second is ketoacidosis. Hypoglycemia, autonomic symptoms like sweating, hunger, trembling, anxiety, pounding heart. Neuroglycopenic, confusion, drowsiness, irritability, inability to concentrate. Non-specific symptoms like nausea, tiredness, and headache. Coming to hypoglycemia, autonomic, neuroglycopenic, and non-specific symptoms, same discussed as previous. Manifestation of hypoglycemia, mild or oral fast-acting carb is taken as a glucose drink, etc. Severe, glucagon 1 mg IM or subcutaneous, 20 ml of 50% dextrose IV is given. Management of diabetic ketoacidosis during pregnancy. Laboratory assessment. If pH is less than 7.3, blood sugars more than 250 mg per deciliters, ketones positive in urine and blood, and bicarbs less than 15 milliequivalents. Insulin bolus 10 to 20 units IV followed by infusion. Loading dose of 0.2 to 0.4 units per kg. Maintenance dose 2 to 10 units per hour. We generally give isotonic fluids, and the glucose begins with 5% D or DNS when plasma level of glucose reach up to 250 mg per deciliter. Potassium infusion and bicarbonate. Coming to fetal evaluation, at 8 to 10 weeks, we have to establish accurate dates with ultrasound. At 18 to 20 weeks, ultrasound for fetal anomalies. At 20 to 24 weeks, we'll generally do fetal echo to rule out the cardiac abnormalities. From 28 weeks, ultrasound for fetal growth and liquor. From 32 weeks, fetal surveillance tests are done, like an non-stress test, biophysical profiles, and Dopplers. When to deliver? It is well controlled. We can GDM is maintained on diet and exercise. We can extend up to 39 to 41 weeks. If it is well controlled with oral hypoglycemic agents or insulin, we can extend up to 39 to 40 weeks. It is poorly controlled, we should deliver at 37 to 38 weeks. Cesarean is not done for only done for obstetric indications. Planned cesarean section if estimated fetal weight is more than 4.5 kg. Weight is more than 4.5 kg. We have to plan for elective cesarean section. Insulin protocol for labor induction. Target glucose levels are 70 to 100 mg per deciliter. Before induction or LSAS, give usual blood time long-acting insulin. Withhold morning dose of insulin and start NS. Once labor starts, if blood glucose less than 70, start 5% D. Monitor hourly blood glucose. Give insulin according to the CBG levels. This is the insulin infusion intrapartumly. If glucose is less than 100, we should not give anything. 100 to 140 will give 1 unit per hour, and 140 to 180 we will give 1.5, and respectively 50 units of insulin, 50 ml of NS, and we'll adjust the dose. Bolus insulin intrapartum period. If it is 60 to 90, previously we have seen the infusion chart. This is bolus chart. If the sugar, blood sugar raised up to 140, 120 to 140 will give 4 units. 140 to 180 will give 6 units. If more than 180 will give 8 units. Newborn management. Early clamping of the cord within 20 seconds of delivery to avoid erythrocytosis. Evaluate vital signs. ABGA score at 1 and 5 minutes. Preliminary physical examination for major congenital malformations. Start early feeding at 4 to 6 hours after delivery. Aim for full calorie intake divided in 6 to 8 feeds per day. Coming to postpartum care, adjust insulin dose, breastfeeding is important, contraception and follow-up. Metabolic assessment after pregnancy with GDM. After 3 days, we should advise for fasting and postprandial sugars. After 6 weeks, we advise for glucose tolerance test. After 1 year and triannually also, patient should take a glucose tolerance test. So future risks to mother and to the baby. To mother, GDM recurrence is 50%. Future diabetes in 20 years is 50%. Fasting hyperglycemia. Early onset GDM less than 24 weeks. WHO require insulin in pregnancy. Who requires these future diabetes in 20 years is generally who requires 20 insulin in pregnancy to baby. Childhood obesity and increased type 2 diabetes mellitus. Coming to summary, to summarize this topic, universal screening ideal for Indian population. One step approach for diagnosis is simple and economical and feasible. Aim to maintain euglycemia. Intensive monitoring diet and insulin is cornerstone of the GDM management. Use of oral hypoglycemic agents and insulin analogs are still controversial. Regular follow-up of patient with GDM is a must to prevent future diabetes mellitus. It is always a team approach. A short-term intensive care gives a long-term payoff in the primary prevention of obesity, diabetes in pregnancy, IGT, as the preventive medicine starts before birth. Prevention is always better than cure. Thank you. Are there any doubts in this topic? Any doubts? Okay, thank you.
Thank